putting this together, and Dr. Whalen for his support in this. And then certainly I'd like to thank Dr. Sandra Wong, chair at Dartmouth Hitchcock, the immediate past president of the Surgical Oncology Society, and the senior author of the paper that's going to be presented by Dr. Connor O'Neill, who we'd also like to thank for being willing to kick us off here today for our, again, New England Surgical Society Intellectual Happy Hour. We thought maybe the happy hour component would stimulate far greater participation, but we'll see. So thank you all very much.
Yeah. You want me to get going, Carlos?
Absolutely. I mean, you know, it's a work in progress. It's an evolution, and let's have a go at it.
So we should probably take a moment though to have everybody swing on and introduce themselves. You know,
I apologize.
That'd be great. I'm Connor. I've been on staff here at the University of Vermont for a couple of years now. I did my surgical oncology fellowship down in Louisville, Kentucky, and now I'm up here. I started doing some melanoma, but for the last couple of years, I really haven't been involved much with melanoma beyond intermediate thickness and sentinel lymph node biopsy patients. I haven't been doing any of the off the rails patients. So this was a good refresher for me as well.
Okay, I'm Giles Whalen. I'm the president of New England Surgical Society right now, and an enthusiastic supporter of this whole idea. And I'm also a surgical oncologist at the University of Massachusetts, and certainly do some melanoma, and have a long-standing interest in nodal metastases, not just from melanoma, but also what leads to them being set up. So I'll let it go with that.
I'm John Sutton, and I'm actually coming to you from South Carolina, where I now live. So the New England Surgical is, I guess I'm probably not really a member anymore. I guess I'm an associate or something, but I did participate for a while, as some of the older people will know. And I have a personal interest because I'm a melanoma patient, and I had a stage 3C melanoma, as well as a more superficial melanoma. So I have an intense interest about melanoma treatment and where it's going. And fortunately, for me, that was 5 years ago or so, 6 years ago now. So at the moment, things seem to be good. So, but interested to participate.
Nice to see you again, John. I don't think of myself as one of the older ones, but I certainly remember all of your contributions to the New England Surgical Society.
I'm a thoracic surgeon, and I kind of deal with the sequelae of metastatic melanoma periodically, plucking out nodal mets in the lung if they're isolated. So I'm looking forward to the presentation this evening.
Awesome. Well, maybe I'll get going, Carlos. So it's a broad topic. Let's see if I can make this work. There we go. You know, I think given how broad it is, I think it's important that we try to narrow this a little bit. When I was a fellow, I just absolutely loved getting into the weeds of all the emerging data. And, you know, we had a very active oncolytic therapy program, and limb perfusion was still being performed. And it was something that I just absolutely loved, but I don't think it's worthwhile to get into the weeds of any of that. And I think that this was a really nice paper that Carlos selected by Dr. Wong. You know, melanoma continues to grow in prevalence, and despite being a visible disease that we can see, we still haven't come up with effective screening paradigms such that the U.S. Preventative Task Force Services still does not recommend for or against routine screenings. And, you know, the real crux of this issue is how to talk about the management of nodal metastasis, I think just for the broader audience, the principles of melanoma still are surgical in nature. We have a wide local excision with the width of that depending on the depth of the melanoma. And sentinel lymph node biopsies are indicated for PT1B and higher melanomas. And that comes from our ASCO and SSO consensus guidelines from Dr. Wong that shows, that melanomas greater than 0.5 millimeters have a positivity rate, sentinel lymph node positivity rate of approaching 9%. Even in head and neck melanomas where there's more of a variable drainage pattern, and targeted studies looking directly at head and neck melanoma have never shown a survival benefit. Still, sentinel lymph node biopsy was feasible and accurate, as Dr. Wong again published on a retrospective review from the Sunbelt melanoma trial. So even though there's some variable uptake with head and neck, still broadly, we recommend PT1B and higher for sentinel lymph node biopsy. And we know that it improves disease-free survival. The big MSLT1 trial showed that sentinel lymph node biopsy improves disease-free survival versus nodal observation at 5 years, with an absolute improvement in disease-free survival of 5%. Now, it didn't impact melanoma-specific survival, which I think is important as we circle back later. In this trial, it really selected patients who had intermediate thickness melanoma. It was a very well-designed, well-randomized trial. And the false negative rate was 3.4%. So it showed the accuracy of a staging sentinel lymph node biopsy. Sentinel lymph node biopsy also gives us really important prognostic information. Patients with sentinel lymph node positive disease, despite a completion lymphadenectomy in the trial, had significantly worse recurrence rates and melanoma-specific survival. But really, the crux of the paper here that we're talking about is how to manage nodal disease that's been identified. And that can either be sentinel lymph node positive disease, so microscopic disease, or macroscopic disease. And so in reviewing her paper, it really is separated by those two factors. Patients who present with sentinel lymph node positive, so they're clinically node negative, versus clinically node positive disease. Now she touches on neoadjuvant therapy, and it's been a hot couple of years in melanoma, and some of those trials have come to fruition. And so I wanted to present some of the data that had not yet been available at the time of this paper, and kind of pause it as a discussion for us about being more selective about lymph node biopsy, and to consider nodal observation in certain patients as well. So historically, even when I was an intern, sentinel lymph node positive disease were treated with completion lymphadenectomy. As an intern, I was talking to my chief today. He took me through some amazing operations. Inguinal lymphadenectomy, axillary lymphadenectomies at levels 1, 2, and 3. About 15 to 20% of patients have additional non-sentinel disease. But that MSLT2 trial that came out, right at the end of my residency, really changed that paradigm. And for those who don't practice melanoma routinely, there were two trials, one in 2016, the DCOG trial, which was underpowered, but still relevant, and the MSLT2, randomized patients who had sentinel lymph node biopsy positive disease, either by standard pathology or in MSLT, also by RT-PCR, to their completion lymph node dissection or clinical observation with nodal ultrasound. They were well-balanced trials, and there was no difference in survival over the course of these trials. despite the fact that there are additional non-sentinel node positivity rates of 18% in DCOG and the actuarial rates at 5 years approaching 20% in the MSLT2. So on that body of evidence, patients who now are clinically node negative, but sentinel lymph node biopsy positive are staged, but if there's no additional disease, observation was pursued. And I think Dr. Wong was really careful to discuss that in her paper, that we need to interpret these results with caution. In this trial, in both of these trials, they underwent rigorous nodal surveillance. In MSLT2, it was every 4 months, then for 2 years, followed by semi-annually and then annually, and then every 3 months in DCOG. And so I think as we discussed the risk-benefit ratio of nodal observation in sentinel lymph node biopsy patients, we have to stress the relevance of nodal observation. And so certain at-risk populations, you could consider a completion lymph node dissection. But, you know, the role of adjuvant therapy has really blown this all out of the water. And every time you look at the news, there's another checkmate trial or a keynote trial, and BRAF and MEK inhibitions for the V600E and K mutations are everywhere. And I think that that's really changed the paradigm. You know, they all have shown a benefit in stage 3B and higher disease. Again, you know, in this review article by Dr. Wong, she's careful to state that this is not a stage 3A. This is not a wide local excision and the sentinel lymph node was positive. These are stage 3B. So they had it, they either were high or thick primary melanomas or ulcerated, or had clinically palpable disease. So these were in completely resected patients who enrolled on these trials. Nevertheless, we've extrapolated that to even our 3As. Well, here at UVM, we tended to not offer adjuvant immunotherapy to 3A patients. But certainly we pursued observation and adjuvant therapy for the 3Bs and higher. And, you know, I guess my first question for the group as I've gone through this is, now last year there was a big another keynote trial. We're now in node negative patients, but ulcerated or thick primary melanomas, you know, T3Bs and higher, were randomized to placebo or adjuvant pembrolizumab. And at 20 months, the relapse-free survival was significantly less in those who received adjuvant pembro. You know, that really even evolves from this paper. And I think that the big question that I have for Dr. Wong and Dr. Whalen, who's on the call as well, you know, where are we headed with sentinel lymph node biopsy? If patients are clinically node negative, but they present with a T3B melanoma or higher, do we need to perform a sentinel lymph node biopsy? You know, I had a patient just last week. You know, my partner's out, so I've started practicing melanoma for the month while she's away. And he had a ulcerated 3.1 millimeter thick melanoma of his right posterior auricular skin. And, you know, I got my preoperative lymphoscintigraphy. And of course, you know, those who do head and neck melanoma, the entire cervical region lights up. There's no obvious node, and maybe it's also in the parotid. And so after struggling, I find a few lymph nodes, which of course on pathology were negative. But either way, he's interested in risk reduction of recurrence of his melanoma, and he's going to consider adjuvant immunotherapy. So did I need to do that? And I'm curious what our more senior surgeons would think about this now that we have Keynote available.
So is that a question for right now, Connor?
Yeah, why not? It's a happy hour.
Yeah, I'll kick in. So I think that's exactly the right question. And you know, I've still been doing the sentinel node biopsy, but but not, but thinking that we're probably not accomplishing a lot extra. Not everybody necessarily goes on to having adjuvant immunotherapy, particularly as they get older. They're less likely to tolerate it and so forth. So I have generally been doing it, but I think that's right. And your point is correct. And I wonder to myself, when are we going to stop doing this? But my rationale for proceeding is still sort of standard of care, and it's still, and not everybody gets immunotherapy, and the lower their risk, the less likely they are to undertake some of the risks associated with the immunotherapy. So I'll be interested to hear what Dr. Wong thinks about that.
Yeah, happy to opine on this. Connor, you did a great job presenting it and setting it up. And I will say, I'll make a couple of like bullet points here. You know, if you look at Keynote 716, all of the patients were adequately staged. So they were sentinel node negative, right? T3B, T4A, T4B, but node negative. So true stage 2B and 2Cs. So, you know, the entry criteria to the trial. So if you're going to adhere to kind of the population in the randomized controlled trial, the sentinel node biopsy actually helps you with that. Now, what I would say is if the decision has already been made a priori that you're going to give adjuvant therapy, one could argue that whether or not you have N1A, N2A disease probably won't change that decision. But I agree that, you know, sometimes that decision isn't the easiest to make, right? Medical comorbid conditions make a difference, cost makes a difference, and certainly we all appreciate that adjuvant therapy is not without toxicity. So if that decision hasn't been made and you're looking for additional information to inform whether or not adjuvant therapy in that population makes a difference, then a sentinel node biopsy can actually help you with that. And I will say there's another component too, which is, and you know, Connor showed the MSLT2 as well as the DCOG trial, but you know, there is a therapeutic effect to sentinel node biopsy. A lot of the times you get, without doing the completion node dissection, you're getting all of the involved nodes. So Connor, I can share a few slides that might that might add a little bit to the conversation if you're interested in that. Let me just put
Sure, why
put it
not?
up.
Put it up.
That'd be
Yeah,
awesome.
since we're having a discussion, right? So let me just put this up. For some reason, I can't get it in presentation mode. So hang on just a sec.
It's okay though.
Can you see it?
Sure.
Yeah, we
Okay.
see it just fine like this.
Yeah, so if you look at these survival curves, and I shrunk the one on screen left to make the y-axis line up. So if you think about it, if you have stage 2B and 2C disease, it actually makes a difference to know your nodal status, right? Because and this is melanoma specific survival. So if you're able to tell a patient because you know their nodal status and they're true 2As or 2Cs, you can say, look, your 5-year MSS is in the 80%. Your 10-year MSS is 75 to 82%. If you actually did the sentinel node biopsy and you actually found nodal disease, they're no longer 2B, 2C. They're actually 3C, 3D. And you can actually tell them that their kind of natural history is that their MSS is much lower. So I would say if your decision for adjuvant therapy hasn't been made, actually knowing your nodal status can actually reassure you if you decide, well, I'm T4A and 0, maybe I won't get adjuvant therapy. But if you're T4A and anything, you can actually say, well, you know, look at your MSS. You may actually want to tip your decision-making into receiving that adjuvant. There's quite a bit of difference in those survival curves between 2B, 2C, and appropriately staged 3C, 3D. So,
Did-
but if you've already made the decision a priori to give adjuvant, then maybe, the sentinel node biopsy adds cost, adds time, whatever. But I would say that for a lot of patients, that decision is not kind of a slam dunk. So I don't know. I would submit that it may make a difference. And then in terms of the, I really like this. Here, I'm frozen here a little bit, so I'm going to reshare. I really like this recent kind of like analysis that was done by Alex Berry in Australia. Again, I can't change to presentation mode, but you can appreciate. So he did this nice modeling, and essentially, if you follow kind of like from the left side of the screen to the right side of the screen, this is really about T3B, T4, clinically node negative patients. And so what it does is it walks you through, and it's a decision model, so it informs it with existing evidence. So if you don't have any sentinel node data, it zips you straight through, and it gives you an estimate that your in-field nodal recurrence rate is 20 to 27%, meaning you haven't done anything in terms of a sentinel node biopsy, so there is actually no therapeutic effect to be had. Now, if you actually go through with your sentinel node biopsy, you kind of estimate a 33% positivity rate based on T3B, T4A, T4B. And if you kind of pull that all the way through, there is a therapeutic effect to finding those nodes, right? Those are adequately staged 3C, 3D patients. And so even with adjuvant therapy, you notice that it changes. And you would never know that from Keynote 716 because everybody in Keynote 716 had a sentinel node biopsy. So anyway, these are slides I took. I just recently gave this talk at ASCO because the medical oncologists are really interested in whether or not you really need to do sentinel nodes anymore in kind of the T3B, T4A, T4B population. And, one of my disclosures is, well, I'm a surgeon, right? But I think if you look at these numbers, especially if it helps a medical oncologist inform those decisions, I actually think that the data we can provide by doing a minimally invasive, potentially therapeutic procedure actually helps. So I'm going to stop sharing, turn it back over to Connor, but I would say that's kind of my pitch, if you will, for continuing to consider doing sentinel node biopsy in that population.
I mean, that makes a lot of sense to me. When I first started, I had a 34-year-old who had a T4B melanoma. And, he was actually, it must have been after Keynote, so not that long ago. He was going to go on adjuvant. He wanted immunotherapy no matter what. And so I guess I'm really just curious, do you have a kind of patient in mind who you might say, yeah, okay, we can omit that procedure? Is it somebody who, maybe doesn't want to have general anesthesia or something, but otherwise is willing to still have adjuvant immunotherapy? It's hard to imagine a patient really that you may consider omitting without giving them some prognostic information.
Well, I think it dovetails into the papers that you selected to add on to this, which is really considering the very low risk patients, T1B, some selected T1Bs, where even if you found N1A disease, you would be at 3A, which I think a lot of us are no longer recommending adjuvant therapy for. So
yeah, let's see.
Yeah, you can go back to because that's your next set of slides, I think.
That was really the crux of it. So, I guess in this mantra to sort of attack the role of sentinel lymph node biopsy, just for the purposes of this talk, I thought on the other end of the spectrum are these really early stage melanomas. Dr. Wong's other papers that we've cited do show that there's a rate of sentinel lymph node biopsy positivity in T1B that approaches 9%. There have been some concerns that this is an overestimated risk, and it's kind of fair because a lot of those are extrapolated from the NC database, from the National Cancer Database, which are institutionally maintained or hospital-based. So those patients who have thinner melanomas that are managed in an ambulatory setting are not going to be prospectively tracked by an NC database. So the only reason why this one kind of sparked my interest a little bit more is they specifically looked at the SEER database because it would give them a broader swath. Now it's a Medicaid or Medicare population base, and it doesn't have as much capture as NCDB, but it may provide more information on those patients who aren't making it to a hospital-based system for their sentinel lymph node biopsy. And so they postulated that rates of nodal positivity could be overestimated. And so in their SEER database, they indeed found that in T1B melanomas, there was a prevalence of just 4.1%. That's relevant because it seems like 5% is the number that we're looking for to say, yeah, that's a risk that we're willing to pursue sentinel lymph node biopsy. If it's less than 5%, maybe not. I don't know why it's 5. It just seems like that's what's percolating through the literature. But those patients who have higher rates are young patients, those who are exactly 1 millimeter depth, and then those truncal ones. Now, mitoses have been dropped from our AJCC staging criteria, but it's still an important prognostic factor for nodal positivity. So it's important, and there's some concern that it'll be dropped from pathology reports since it's no longer required for staging, but has important prognosis for us to determine when to perform sentinel lymph node biopsy. And on the basis of this, they said that that's a number needed to treat of 25. It's expensive to put somebody under anesthesia and do a sentinel lymph node biopsy, almost 10-fold more expensive. And so what they estimate is to identify one sentinel lymph node positive T1B patient, it's $71,000. When this paper came out, I was still in fellowship, and one of my faculty wrote the commentary with this, and I actually thought he had a very measured response. And he said, well, what exactly is the appropriate cutoff that we're chasing here? It seems like 5% is where we're determining a threshold, but what's an acceptable number needed to treat for us as a healthcare system? And what is an acceptable cost to the health system? Because we would all agree that immunotherapy is not cheap. So is 71,000 too much? And age is inversely proportional to the rate of nodal metastasis, and we need to be paying attention to a young patient. So we clearly need a little bit more nuance in who we offer T1B biopsies for, or sentinel lymph node biopsies for. And it doesn't have to be all comers, but we need to be appropriately nuanced. You know, while it was 4.1% overall, within that paper, they do mention that a young female patient with a truncal melanoma, that's 1 millimeter, she has a nodal positivity rate approaching 17%. So then her number needed to treat as 6. So Egger and Dr. McMasters then did a CART analysis, and they published their algorithm that we used in fellowship about how to treat T1B melanomas. And I kind of like the tree bud regression analyses, but basically patients who have no mitoses, you know, their node positive rate is low, especially if they're, you know, non-ulcerated melanoma, but ulcerated and truncals have higher positivity rates. Younger patients have higher positivity rates. And by using one of their algorithms, they feel like they're being more appropriately selective in the use of sentinel lymph node biopsy. That's kind of what I took from that paper and some of my review thereafter. I have become more selective in how I offer lymph node biopsies. When I have an elderly patient with a head and neck melanoma and it's 0.8 millimeters, I'm just doing a wide local and getting them off, especially when they come in with oxygen, you know. But if I have a 34-year-old with the truncal melanoma, you know, I do a sentinel lymph node biopsy in those patients. And, you know, I'm curious how you guys may also choose to be more selective, or if you're routinely doing T1B. My partners all T1B, they just do sentinel lymph node biopsy. I think there's probably a role for being more selective.
This is Frank Podbilski. I have a quick question for you. You'd mentioned that if you don't do the sentinel lymph node biopsy, you have to do really pretty intensive nodal clinical follow-up with physical exam and ultrasound. Does that to a degree play a role in your decision to do the biopsy if you know the patient that you're operating on with melanoma is not really going to be coming in to see every 2 or 3 months for an indefinite period of time?
Yeah, I think that's a good point. I'll tackle some of that for just myself in my very early clinic without longevity yet. But the nodal surveillance patients really referred to those who you omitted a completion lymph node dissection on. More aggressive nodal surveillance may not be warranted in patients who have thin primary melanomas, and we're staging them as node negative based on clinical exam. That being said, in practice, the ones that I'm not biopsying are young or are old patients who've got other things to deal with, like getting to their cardiology appointment. And so I'm not as aggressive in removing in doing nodal observation in those patients. And then the younger patients, I've primarily staged their lymph nodes. And so then I know how to surveil them going forward. At least that's how I'm doing it.
Yeah, I mean,
It's
I
a good
think,
question. I mean, you have that, I'm sorry, go ahead.
no, go ahead, Sandra. You're the star of the show here.
Well, I wouldn't say that. I think it's a tough question about, observation and surveillance and expectant management, right? Because I think if you kind of made the decision based on medical comorbid conditions, I'm not sure that you're accomplishing that much by doing the surveillance, right? Because the decision making was taken down a different path. However, sometimes every once in a while you get a non-mapping, right? You send them down to nuclear medicine, they come back, there's nothing on the scan. I think in those situations, I would follow them because the decision had been made to do a sentinel node and there was no sentinel node to be had. So I think I approach kind of expectant management with intent rather than, I mean, obviously, I think your point about whether a patient would be compliant with doing the surveillance is valid, but I think taking a decision-making perspective on it, I would say that doing observation with close sonographic follow-up at intervals is largely predicated on what you would do with that information.
Right. So that's one of the questions. I think you froze up, Sandra.
Sorry.
So would you guys, so somebody has a T1B lesion and a positive, microscopically positive sentinel node, you would go ahead and give them, and they're young, you would give them recommend immunotherapy, checkpoint inhibitor adjuvant therapy.
We haven't been doing it for 3A, I will say, and there are some patients with sort of kind of what I would consider low risk 3B, where you go through some shared decision making with the patient and they decide not to do it.
Right.
And I think increasingly we know that if you save, in air quotes, if you save therapy, and right, because it's adjuvant versus treating when they're metastatic, and we know that a lot of times if they show with metastatic disease, they respond very, very well to current therapies. So I don't know that you should feel that bad about not treating 3As and low risk 3Bs, quite honestly, in an adjuvant
I get
setting.
confused though, because we have keynote data showing 2B, 2C have a relapse-free survival benefit, and we have stage 3Bs and Cs that have a benefit, but this 3A, we're sort of in a data void there. I find that an interesting mix, that those are the patients that you're right, we're not treating. I didn't treat 3As, but now I feel more obligated to treat them since I have keynote 716 saying I should treat earlier stage patients with immunotherapy.
Yeah, but remember our staging system is really about prognosis and not about prediction, right? AJCC is really about prognosis. So if you really think about it, your prognosis with a 3A at 5 years and at 10 years, you're much better than if you're a 2B or a 2C. So, and that's, addition after addition after addition. I think we're ripe for a change. We know that other cancers, they've really kind of been a little bit more innovative with staging. Melanoma has really been T, N, and M, and the N really drives the stage 3.
So Connor, the way I think about this is that whether or not you're going to do a sentinel node on someone with a TB more or less depends on what you intend to do if the node is positive, right? I don't personally go ahead and start doing ultrasound evaluations on every T1 lesion that I'm following. And one of the questions I ask about it of myself is how long should one be following these folks over what period of time? Because, everybody has the experience of folks turning up much later in life, not much later, but years later than 5 years, and with nodal disease and so forth. So it's a tough call, but it's do you get to omit the ultrasound as part of appropriate follow-up if you haven't done a sentinel node biopsy? It's an interesting question. I think probably yes, just at a practical level, but and certainly I'm very selective about it with older patients, as you indicate. I mean, if you're looking at somebody who's going to die of something else in the near future, the risks of the melanoma sort of recede, in my opinion.
Yeah, I agree. All right, so I know we don't have tons of time. I'll try to pivot. She mentions radiation, and we all know that maybe except for primary treatment and pure desmoplastic melanoma, radiation doesn't have much of a role. And so I think the other thing to tackle is the clinically node positive patients who present. Until data were published recently, patients with nodal disease underwent upfront resection. In fellowship, we never did that, but they all had some kind of trial. And then I started here and somebody had node positive disease and I wanted to put them on neoadjuvant therapy. And they said, with what protocol? And I had to do a therapeutic lymph node dissection on this patient. I felt like I was trapped back in the 1980s. That being said, Dr. Wong mentioned several trials in 2020 that were ongoing, looking at the role of neoadjuvant treatments. She postulated then that neoadjuvant therapy may have a real role because we know that there's tumor in place and it may induce a better response. These were great operations, the axillary levels, superficial groin dissections, epitrochlear, popliteal. I loved them. But some of that data, has come to bear. And I think it's worth mentioning, the top 3 that she said in her trial or in her paper come out. One of them is the Combi Neo, just like the Combi AD, that looked at the role of BRAF MEK inhibition in V600E patients who got neoadjuvant therapy for 8 weeks. So it's an oral pill they took daily, and then 44 weeks adjuvantly versus just adjuvant treatment. And they had a significantly higher event-free survival. And they didn't have any significant or grade 3 or grade 4 adverse events. The Relativity trial also had a neoadjuvant arm that was published in 2022, I think in Nature. And these patients who presented with stage 3 disease and resectable stage 4, so Francis, this would be right up your alley. They got 2 doses of Nivo and relatlimab, followed by surgery and then adjuvant therapy. They had a pathologic complete response rate, 57%. And SWOG, which we tried to enroll in here, but it didn't work well because they had disease had to be measurable by RECIST and on CTs, and we had a local predilection for PET CTs. It just didn't work well for us. But the SWOG, which was published just a couple of months ago in New England Journal of Medicine, did neoadjuvant Keytruda for 3 doses and then 15 doses of adjuvant therapy. Treatment-related adverse events were the same. Event-free survival was significantly better with a 21% pathologic complete response rate. Now that we know that we're having such a strong response rates, this was just another SWOG showing that there was, significantly reduced event-free survival. or improved event-free survival, excuse me. So I think that brings us to the role of lymph node surgery. You know, almost none of us have really encountered real significant clinical lymphadenopathy after a sentinel lymph node biopsy, but it's not without any morbidity. And we've all had to drain seromas and these non-healing seromas just from lymph node biopsies. So I'm kind of curious, Dr. Whalen and Dr. Wong, you know, what's our trajectory here for clinically converted patients who were node positive and then have converted? You know, this other trial that I sent out was really an expansion cohort of the phase 2 trial that was looking at optimal dosing strategies for neoadjuvant nivolumab and IPI. And so these patients had 2 cycles of IPI-NIVO if they had stage 3B or C disease, and they had a clipped lymph node, just like in, you know, our breast cancer trials. That clipped lymph node was removed, and if they had major pathologic response, so less than 10% viable tumor, they went on observation. And those who didn't have a response underwent therapeutic lymph node dissection and adjuvant treatments, or, you know, follow if with BRAF if they had a BRAF mutation. So 90% of patients received both of their cycles. Only 13% of them had progression, but only 6 patients of those 99 developed distant disease in that time. Removing the clipped node was feasible. You know, 90 of 94 patients had their nodes successfully, the clipped node successfully removed, and they had major treatment response. 84% of patients had radiologic disease control with either stable disease or responsive disease, and 61% of them had less than 10% viable disease on their index lymph node, with, you know, partial responses in 11%. So, you know, total response rates were 72%. And importantly, radiology underestimates that response rates in probably about 25% of patients. Certainly, by omitting this lymph node dissection, their health-related quality of life scores were improved. And these patients had median relapse-free, distant met-free, and overall survival curves that were not reached over the course of this study, with a 2-year relapse-free survival of 93%. You know, 4 had recurrences in the partial path responses. All of them were distant disease, so their distant met-free survival was 4%. So it also gave us some important biological information. And there's the ongoing NADINA trial too, which is looking at neoadjuvant IPI-NIVO, followed by lymph node dissection if they did not have a complete response, or observation of major pathologic response. So, you know, clearly downstaging is on the rise. You know, I'd postulate perhaps we can even avoid the index lymph node biopsy. We're enrolled in the PET-STOP trial, which I think several centers, just of the institutions on this call, are enrolled in PET-STOP, where we have unresectable stage 3B or sometimes 4 disease, and we're just following PET biomarkers. And if they have no viable disease, you can biopsy it and prove that there's no viable disease. Or if you can't biopsy it and it's no longer PET avid, you can just watch it. So I'm curious now, in these clinically converted patients, are we moving in the mode of breast cancer, and we're going to do nodal observation without a completion lymph node dissection? Do we even need to remove that clip node? That's all I got.
So I'll you know, kick in and say I don't know. There are a couple of biologic questions that sort of circle around this that I wonder about, and one of them is, I was interested to hear Dr. Wong talking about basically the sentinel node biopsy basically is resection of oligometastatic disease. It just happens to be a lymph node in the regional area. showing some difference. But then if you look at the melanoma specific survival after that's no different. So, and the MSLT2 trials, no different. So there's obviously more that's happening in these patients than simply the removal of the disease. And here you're seeing a little bit of it, which is if they're responding to a treatment, they're, you're really quite adjunctive to what's going to happen to the patient. Having said that, it's interesting. Well, let me put it this way. So when you have a lot of tumor, right, the opportunity for you to develop resistance from your treatment, you would anticipate would go up. And so you would anticipate with immunotherapies as well as many others, that if you clear the disease so that it's only microscopic, the chances of, if you will, success would be substantially improved compared to trying to treat gross disease. And yet here we are treating gross disease with immunotherapy, up front and achieving somewhat better results, suggesting that perhaps, you're going to one will have to come up with a reason. And the reason is that we tell ourselves is that we're sensitizing the lymphocytes to the tumor while the tumor is still there for them to be sensitized to. But it's, how that all plays out with this going forward is really quite interesting. And I will defer to Dr. Wong as to what she thinks is going to happen with this.
Don't defer to me necessarily. I will say, the last 10, 12 years for melanoma, really even just 10 years, has been so exciting, right? We've gone from having interferon and IL-2 to having just such success stories. And I will say your comment about disease biology is spot on, because I actually think that immunotherapy for nodal disease versus immunotherapy for just widely metastatic disease is very different. And I think it's immunology principles, right? We know that, when we treat for stage 4, it's potentially remarkably effective. So that's why I think the enthusiasm for adjuvant therapy has waned a little bit, even in high risk 3C, 3D. So I think this is going to be an ongoing good news story. We just need to sort out what patients are likely to benefit the most versus the patients who, we're treating because we think we should, and we're trying to give them the best shot. But I think really and truly, this is going to end up being about patient selection, both for sentinel node, for completion node dissection, for treatment after neoadjuvant, but also for kind of, very advanced stages.
Yeah, the ones I struggle with are if somebody comes in with gross nodal disease and you treat them, and with immunotherapy of various sorts, and then they get the toxicity and they can't keep up with it, or they don't respond, and then you go ahead and resect them, but they've got a lot more disease there, and so on. So it's not, in those circumstances, you wonder if you could spot that coming ahead. Would you do something different? The other thing that I will tell you that I've been thinking about is when somebody has a solitary node in their, say, axilla, and they're treated with immunotherapy, and the solitary node, shrinks a bit but doesn't go away, and then they can't carry on the immunotherapy. Do you really need to do a node dissection, or can you just remove the focus of disease? When you're talking about the PET positive metastases that you go after they've had a successful run being treated for metastatic disease, and now they have a solitary recurrence, and it's, theoretically oligometastatic disease. When you're going after that, you're basically doing fairly limited resections of whatever it takes to get the metastatic lesion out, which is, different than, I feel like we carry our plan forward for clearing out all lymph nodes because that's what we've always done. And if you have one abnormal node there, you really need to subject them to the toxicity of the entire nodal dissection. So I don't know. So that was one of my questions. And then do you guys think about that? And then the second question was, is anybody using Castle Biosciences to try to sharpen up their decision making on whether or not to offer adjuvant or
Boy,
adjuvant?
I tell you, I think we could do a whole other intellectual happy hour on GEPs. I mean, really and truly looking at GEPs for breast and for melanoma. Interestingly, CMS just released a limited coverage determination. I think it's open for public comment. I think a lot of the GEPs are not going to make it through. There's some that are clearly very good, and there are some that are barely additive in terms of the information. So
Yes.
I think
I ha-
TBD for that.
I haven't been using it for this.
These are some, I mean, what a great discussion. And, that's the whole point of this. Dr. Whalen said something earlier. So I full disclosure, I don't do melanoma anymore, not at all, really, and never really did with any significance other than through fellowship, where we saw some amazing stories. But I think, to me, the underlying message is this is all about the biology, right? We talk a lot about the biology, which is critically important. We have new agents, better agents. And the big, the shame of it all is that everyone has seen some amazing responses, some great responses that, I remember Rosenberg putting up these specific, patients that, would respond. And he was a great market man. He is a great market man. And, there were times we'd have, congressional, committees coming to the NIH, and we had specific patients already lined up to present. But the big thing is this, it's all about biology. We have better agents. And I think Dr. Whalen at one point talked about, well, how long are you going to do your ultrasound for? How long are you going to do your staging for? And is 5 years enough? And the reality is so many different things can happen biologically. Did you get the flu that subsequently, what was the danger signal that Polly Meitzinger would talk about that subsequently changed your immune responsiveness to that tumor? Or what actually changed in the tumor that resulted in resistances? And so the big thing comes down to, the follow-up and being able to capture things so you can actually identify the oligomets to do something about. And that's where new diagnostics have been great for a lot of things. And then subsequently they fail us in so many other elements. And a lot of these things come down to cost, right? How long are you actually going to do these things for? But that's the neat thing about melanoma is it teaches us so much about the biology and monitoring and trying to make an effort to understand the biology of the disease. This has been phenomenal. It really has been. And I would say that just through tonight, Dr. Wong already identified a whole new intellectual happy hour, but I would actually submit that potentially just through this interaction, I think the three of you could probably sit down and actually put together a new trial to find those the approach to those 3As and so on. And, again, I think this has the potential. There have only been 8 of us on the call, but has the potential to really generate some really neat collaborations, scholarly in nature. And then I'll also throw something out there that I think is near and dear to Dr. Whalen's heart. We may actually have an institutional Jeopardy competition at some point. So everybody should, sort of stay tuned. I want to thank everybody for participating. Dr. Wong, Connor, that was a phenomenal job. That really was outstanding.
Yeah, thank you, Connor.
You owe me,
and-
Carlos.
Well, I just tell you that, I think the greatest way to repay you is probably to suggest that presentation needs to be done for our staff and residents, because that was a class act. That was second to none, and that was just tremendous. One of the things, and hopefully you'll talk to different